Hello everyone, this video will talk about keratoconus. Keratoconus is a common disorder that occurs in approximately 1 in 2,000 individuals. The prevalence of keratoconus in first-degree relatives is 3.34%, with a slight female predominance. Cornea in keratoconus undergoes progressive thinning and protrusion in the central, inferior paracentral, or inferior midperipheral cornea, resulting in a cone-shaped cornea. Here in the picture you can see the difference between the normal cornea and the cone-shaped cornea on the right. Risk factors of keratoconus are eye rubbing, which is also associated with atopy or vernal keratoconjunctivitis, floppy eyelid syndrome, retinitis pigmentosa, connective tissue disorders, sleep apnea, and lastly, Down syndrome. It's necessary to know that the majority of cases are bilateral, but often asymmetric. The less affected eye may show a high amount of astigmatism or mild steepening. Onset is typically in early adolescence and progresses into the mid-20s and 30s. Progression typically slows in the fourth decade of life. A thorough and complete eye exam should be performed on any patient suspected of having keratoconus. Common signs of keratoconus include scissoring of the light reflex on retinoscopy. It is an early but nonspecific sign that commonly associated with irregular astigmatism. Munson sign is a late-stage nonspecific sign involving inferior deviation of the lower eyelid contour on down gaze. As can be seen in the clinical photo of Munson sign, it shows the downward angulation of the lower eyelid with the eye in down gaze. Rizzuti sign, when a pen light is shown from the temporal side, lights will focus within the nasal limbus. It's an early but nonspecific sign. Fleischer ring is a circle formed due to iron deposition within the base of the cone. It is best seen with the slit lamp using a broad, oblique beam, or diffuse illumination with the cobalt blue filter. Voigt striae is a fine, parallel lines observed in the posterior stroma at the apex of the cone. Apical scarring. This is a broad, oblique slit lamp image shows the mechanism of superficial reticular scarring in keratoconus. The white arrow indicates breaks in Bowman layer, while the black arrow indicates where collagen has presumably filled in a previous break. Acute hydrops is a sudden onset of corneal edema that results from a tear in descemet membrane. It's usually observed late in the disease course. Therefore, it is important to caution these patients against eye rubbing because it contributes to disease progression and increases the risk of hydrops in advanced cases. Here is the clinical photo of acute hydrops, showing a corneal edema due to sudden rupture of descemet membrane. It's important to know that corneal edema typically clears within 3 months, but it can lead to posterior stromal scarring. Key information. Clinicians should consider the possibility of keratoconus in young patients who require frequent changes in their eyeglass prescription due to increased myopia and astigmatism, or whose refractive error cannot be fully corrected with spectacles. A young patient with an unusual corneal contour who is considering refractive surgery should be observed over time to determine the possibility of progression toward keratoconus. Serial imaging is necessary to determine whether ectatic changes are stable or progressive, or if subclinical keratoconus has progressed and is likely to become symptomatic. Diagnostic procedures include slit lamp examination, retinoscopy for assessment of scissoring reflex, anterior segment OCT, computerized corneal topography, hard or gas permeable contact lens trial, so in case that vision has improved with lenses, this will support the diagnosis as well as eliminates other sources of poor vision, like amblyopia. The topographic findings in keratoconus patient are increase overall steepening more than 47.2 diopters, and here in our patient it's 57.4 diopters. The axial map shows the inferior steepening, which is represented by warm colors, while the superior flattening is represented by a cool color. Increase in inferior to superior ratio more than 1.2, which is calculated as the difference between inferior and superior dioptric values in two opposing points. The typical topographic pattern in keratoconus is asymmetric bow tie, but it's not pathognomonic of keratoconus, and it's ultimately lost as disease progress. The goals of treatments are to provide functional visual acuity and to halt changes in the corneal shape if progressing. Eyeglasses. or contact lenses. Used to in mild cases, however, it does not prevent keratoconus progression. Corneal crosslinking is a minimally invasive treatment using riboflavin and UV light to induce stiffening of the corneal stroma. It performed to arrest or slow the progression of corneal ectasia in its earlier stages to preserve visual function. It is the first-line treatment for mild to moderate cases who demonstrate progressive disease, particularly adolescents. Intrastromal corneal ring segments. Circular arc is surgically implanted to center the cone to treat mild to moderate keratoconus associated with contact lens intolerance to facilitate successful contact lens wear. Penetrating keratoplasty refers to surgical replacement of the host cornea with full-thickness donor corneal tissue. Indications of penetrating keratoplasty are contact lens intolerance despite the good vision achieved with the lens, unstable contact lens fit, even with good vision and lens tolerance, corneal hydrops that fails to clear after several months, poor vision even with a comfortable stable fitting contact lens, progressive thinning toward the corneal periphery approaching the limbus, because it requires a very large graft in which it's associated with increased risk of rejection. Corneal hydrops is treated conservatively with topical hypertonic agents and/or soft contact lens for several months.